Reactive arthritis. Reactive spondyloarthritis is a reaction to a number of bacterial triggers with clinical features in keeping with all spondyloarthritis conditions. The known triggers are chlamydia, campylobacter, salmonella, shigella, and yersinia. Notably, non-spondyloarthritis-related reactive arthritis can occur following infection with many viruses, Mycoplasma, Borrelia, Streptococci, and Mycobacteria, including Mycobacteria leprae, which causes leprosy, Hansen's disease. However, the reaction in these instances consists typically of myoarthralgias, is not associated with HLA-B27 and is generally not chronic. The arthritis associated with rheumatic fever is also an example of a reactive arthritis that is not associated with HLA-B27. Sexually acquired reactive arthritis, SARA, is predominantly a disease of young men with a male preponderance of 15:1. This may reflect a difficulty in diagnosing the condition in young women, in whom chlamydia infection is often asymptomatic and is hard to detect in practical terms. Between 1% and 2% of patients with a non-specific urethritis seen at a genitourinary medicine clinics have SARA. The syndrome of chlamydial urethritis, conjunctivitis, and reactive arthritis was formerly known as Ritter's disease. With enteric triggering infections, enteropathic reactive arthritis, HLA-V27 may predict the reactive arthritis, and its severity through the condition occurs in HLA-V27 negative people. The incidence of specific triggering infections causing reactive arthritis around the world varies, depending on the epidemiology of the infection and prevalence of HLA-V27 in the local population. Now, the clinical features. The onset is typically acute with an inflammatory enthesitis, oligoarthritis, and/or spinal inflammation. Lower limb joints and entheses are predominantly affected. In all types of reactive arthritis, there may be considerable systemic disturbance with fever and weight loss. Achilles insertional enthesitis, tendonitis, or plantar fasciitis may also be present. The first attack of arthritis is usually self-limiting, but recurrent or chronic arthritis can develop, and about 10% still have active disease 20 years after the initial presentation. Low back pain and stiffness due to enthesitis and osteitis are common, and 15 to 20% of patients developed sacroiliitis. Many extra-articular features in reactive arthritis involve the skin, especially in SARA. Sarcinate velonitis, which starts as vesicles on the coronal margin of the prepuce and glans penis, later rupturing to form superficial erosions with a minimal surrounding erythema, some coalescing to give a circular pattern. Keratoderma belonergica, which begins as discrete waxy yellow-brown vesiculopapules with desquamating margins occasionally coalescing to form large crusty plaques on the palms and soles of the feet. Pustular psoriasis, nail dystrophy with some ungual hyperkeratosis, mouth ulcers, conjunctivitis. Uveitis, of which is rare with the first attack but arises in 30% of patients with recurrent or chronic arthritis. Other complications in reactive arthritis are very rare but include aortic incompetence, conduction defects, pleuropericarditis, peripheral neuropathy, seizures, and meningoencephalitis. Now, the investigations. The diagnosis is usually made clinically, but joint aspiration may be required to exclude crystal arthritis and articular infection. ESR and CRP are raised. Urethritis may be confirmed in the two-class test by demonstration of mucoid threads in the first void specimen that clear in the second. High vaginal swabs may reveal chlamydia on culture. Except for post-salmonella arthritis, stool cultures are usually negative by the time the arthritis presents, but serology may help confirm previous dysentery. Rheumatoid factor, ACPA, and ANA are negative. In chronic or recurrent disease, X-ray shows periarticular osteoporosis, proliferative erosions, notably at emphasis, periostitis, especially of metatarsals, phalanges, and pelvis, and large, fluffy calcaneal spurs. In contrast to ankylosing spondylitis, radiographic sacroiliitis is often asymmetrical and sometimes unilateral, and syndesmophytes are predominantly coarse and asymmetrical, often extending beyond the contours of the annulus, non-marginal. Radiographic changes in the peripheral joints and spine are identical to those seen in psoriasis. Now, management. Acute reactive arthritis should be treated with rest, NSAIDs and analgesics. Intra-articular or systemic glucocorticoids may be required in patients with severe monoarticular synovitis or polyarticular disease, respectively. There is no convincing evidence for the use of antibiotics unless a triggering infection is identified. If chlamydial urethritis is diagnosed, it should be treated empirically with a short course of doxycycline or a single dose of azithromycin. Treatment with DMRDs, usually sulfasalazine or methotrexate, should be considered for patients with persistent marked symptoms, recurrent arthritis, or severe keratoderma bullonerogica. Anterior uveitis is a medical emergency requiring topical, subconjunctival, or systemic glucocorticoids. For DMRD recalcitrant cases, anti-TNF therapy should be considered.